And good morning. It is October 31st, Halloween 2023. I'm Dr. Deuk, CEO and founder of the Deuk Spine Institute. I'm here with my A-team in the operating room. We're getting ready to, thank you, perform surgery on a patient who travels here from New York. Now, he has been suffering with back pain for
12 years in total.
12 years or longer. And he's actually undergone surgery in the past at the Laser Spine Institute. Sean? He had a laminectomy, microdiscectomy. It's a very small incision. I think you can see it somewhere around here. Luis, did you mark that out or no?
No.
All right. Anyway, he comes to us now with basically complaints of back pain. He has pain emanating from his facet joints, but also the discs. So we're going to fix both today. Is he hiccuping or? I'm okay with it. I just don't know what he's.
How you doing, my friend?
It's like tensing up in his legs.
Yeah, lay still. Good. Very good. AP? So we have 3 discs that are causing back pain. The number 2, 3, 3, 4, and 4, 5. Shot? Perfect. Knife. And we're going to fix these 3 discs on both sides, left and right, because he has symptoms of leg pain on both sides. He has herniated discs on both sides with stenosis. He's just sensitive? Shot? That's fine. As long as you're okay, I'm okay. Shot? All right. I've already gotten nice and close at 4-5. We're going to go into that disc right now. Shot? And then we're going to get to the 2-3 next. Shot? And I'm going to try to get it through the same incision. I'm using my X-ray machine to navigate my needle. Unfortunately, sometimes we just have to bite the bullet and make a separate incision a little bit higher up. I may have to do that. Let's just see if I can't get to where I need to be. Shot? I'm touching the facet joint. It looks good. I'm going to try to get a little bit more lateral by angling the needle a little more lateral. Shot? Right there I'm hitting the transverse process, so I need to go a little bit further north. Shot? That's nice. I think we might be able to get there like this. Shot? Shot? When I say shot, what I'm doing is I'm taking an X-ray picture. Shot?
There's somebody here, Jay.
Oh yeah, yeah. He's supposed to go into the video conference room.
Okay.
Have him join Henry and Sanjay. Shot? Shot? All right. Almost there. Shot? I feel the facet, and we're getting around it. Shot? That looks really good right there. AP? If you have questions while you're watching surgery, feel free to type them up in the dialog box. We're live streaming on Facebook, LinkedIn, YouTube. Yeah, I'm going to have to go probably, well, I might be able to get this. I'm just north of the transverse process. So it looks pretty good. Yeah, it's not terrible. We've cleared the TP. Shot. Shot. That feels good right there. If I can just slip around. Shot. Feels like I'm rubbing right on the TP. Shot. AP. The TP stands for transverse process. I'm just above it. I think I've slipped around the facet joint. If I can get this in, that would be perfect. Shot? That looks really good, actually. I'm pretty happy with that. We're right at the back of the disc on the left side at 2-3. And our plan is to fix L2-3 on the left, L4-5 on the left, and is he reliable?
Hello, my friend. How are you? Are you okay? Can you hear us? Hello?
That feels good, Sean. Yeah, that feels good. Okay, we're going to go to the right side because we're fixing both sides. His herniations are on both sides. Let me just see here. I want to enter around the same place as the other side. He does have a little bit of scoliosis. Numb. We're going to give him some numbing medicine. Thank you. This is numbing medicine here. Can you guys see this, Henry?
Yes, we can.
And the numbing medicine will numb up the muscles and fascia and make the procedure more comfortable for the anesthesiologist and the patient. Both. Do I need to do a little numbing for you, Dr. Berndes, today? Huh? Do I need to numb something for you?
You can numb
Your-
my fourth molar.
Your inferior alveolar nerve? All right, shot. Well, Henry, why don't you show our audience how is it that a herniated disc can cause so much pain for a patient? What's the mechanism? Shot. Welcome back. You can see from the video how damaged discs, we call them injured discs, can actually cause so much back pain. And the answer is through inflammation. Inflammation is the key. Without inflammation, there's no pain. Right, Dr. Berndes? Yeah. Inflammation is the reason why people have pain. Let's get a guide wire. So the problem I'm having right now on the right side is his back is pretty deep, his spine is pretty anterior, which means that the needle I'm using is actually long enough to do the job. However, it is allowing the head of the needle, the hub of the needle, to be right where I need to put my next needle. So if I don't do anything about it, then I'm not going to be able to position the next needle and direct it in the trajectory I want it to go. Okay, it's being blocked. It's being blocked by the top of the needle, this plastic part right here. So by removing, this is a little technique I developed here, removing the prior needle but placing the guide wire button and removing the needle, it gives me more room to move around and navigate the second needle. All right, So our second needle is going to go to the L3-4 disc, which is almost where I'm aiming, right there. Now what's making this surgery a little more difficult for me is the patient does have scoliosis, okay? And the scoliosis is basically a twisting of his spine, and his spine is twisted away from this side towards the left side. It made my left side easier to do, but made the right side a little harder. Yep, just put pressure there, good job. Let's get an AP. We're using X-ray guidance. What does that mean? Move your hand. It means that we're using a machine that makes X-rays, which you've all had X-rays before, right? You went to the dentist, they did X-rays on your teeth. X-rays allow doctors to look through soft tissues. When you go to the dentist, they're looking through your cheek. And they're seeing your teeth, right? So all the soft tissues disappear or melt away, and basically you're left with the hard tissues like teeth. So in this case, we're seeing his spine. We're melting away his skin and fat and muscles and ligaments and tendons, and we're left with the spine. And that's what we really want. We want to see his spine. So I'm using his spine to navigate. I'm using his spine to localize, along with the X-ray helping me. Shot? All right, we are now at the bottom of the L3-4 disc, and I'm entering the L3-4 disc. Through the tear, by the way. Good. We've got one more, and I think I'm going to have to make a second incision. Because of his scoliosis, I'm not going to be able to get to the next disc up higher at 2-3 on the right with the same incision. So I'm going to have to go a little bit higher. And that's fine. He's going to have these 3 incisions for the laser surgery. Then he'll have another couple of incisions for his plasma. He is actually having the Deuk plasma rhizotomy done as well. And the reason for that is he has not just disc pain, but also facet pain. So we're going to fix the disc pain and the facet pain today. Yeah. You can see how much further away that other disc really is. Shot? I'm hitting his spine right now. I think I'm just too medial. I'm going to have to go a little deeper. Shot? Shot? Now I can use this needle to navigate for me. It has the tip is beveled. It's called beveled, meaning it's been machined so that it's longer on one side than the other. And what that does is it allows me to navigate the needle to certain places. Let's get an AP. It allows the needle to move in a favored direction. And I can look at the X-rays and figure out where it needs to go. Wow, look at that. I mean, we seem to be a little low there. So I may have to go even higher than I am. Let's just see. Yeah, I think I'm going to have to come in a little bit higher. So the contour of his spine is really causing me to have to come from a totally different location to get to the right L2-3. Shot? I think, and you can see his facets. Hey, this is a great picture. Jordan, let's show the audience his facet joints. Look at how dark they are, folks. He's circling them. They're the big dark things back there. Now go up to a normal joint higher up. There's a normal joint. See how light it is? The reason why these lower facets are darker is they're full of arthritis. The arthritis causes hypertrophy of the facet, meaning enlargement. Shot? And what's happening is the facet joint is actually enlarging over time to accommodate the stress of abnormal movements. Shot? We call it facet arthropathy or hypertrophy. Does not need to be fixed in and of itself, but it does cause pain. And we're going to be addressing that pain today through the Deuk plasma rhizotomy. Any questions from our audience? AJ, you're welcome to ask questions as well.
Yes, we have a question from Janice on YouTube. They asked, can the DLDR also be done on a bulging disc? If not, what course of action would you take for a bulging disc?
Well, Janice, thanks for asking. You are correct. The DLDR can be done for a bulging disc. And most importantly, that's the DLDR's favorite problem to fix is bulging discs. The DLDR can fix a bulging disc beautifully. It's the best treatment in the world for a bulging disc. Okay, wonderful. We are just about done placing our needles, and I'm going to wake this patient up in just a moment, and we're going to do what we always do next, which is a discogram. Look at that. This is the L2 needle on the right. Normally, the L2 spine is closer to the back, and the needle would be a lot less deep. But these needles are being maxed out. That just shows you how deep his spine really is. Meaning he has a lot of soft tissue between us and the spine. All right, I'm going to show you what he's got. Remember, he has how many years of back pain that we know about? 12 years. 12 years of lower back pain. I can write left-handed, but I can't write upside down, so bear with me. Lay still, okay? 12 years of back pain. He is actually from New York.
Good, we're going to ask you some questions.
He has not been able to get any good help in New York, so he came to Florida. And that's where we diagnosed over the internet. We did an MRI review. Lay still.
You're doing great.
He's just waking up, folks, so when you wake up, you're a little groggy. Remember, he's got the two herniated discs at L2-3, left and right, and he's got nerves coming down. The nerves go out, and down your legs, right? They go out at every disc, and then they exit the foramen, and they go down your legs. They're called the cauda equina, or nerve roots is another name. So the problem is he's got these herniated discs on both sides at L2-3, and those nerves are getting pinched on both sides. And he's got leg pain on both sides. So we're going to fix the leg pain on both sides. At L3-4, lay still, he's got a herniation on the right that needs to be fixed, which is why we're doing the right L3-4. And then at L4-5, he's got herniations and tears on both sides. So it's the tear that causes the back pain. It's the herniation, usually, that pinches the nerve and causes the weakness, numbness in the legs. We're going to fix both issues. All right. So for those of you who have watched our surgeries before, you know what comes next. Are you awake?
Yes.
Are you comfortable? All right. We're going to put you to sleep in a moment. Are you having any back pain? How bad is that pain on a scale of 1 to 10? 10. Is that where you typically get back pain? Perfect. We got 2 more to go. Is that better now? We just tested the L2-3 disc. You can see it on the x-ray. Show us, Jordan. Henry, take a look at this x-ray. Side view, you can see the disc full of dye. Look how disrupted it is. That black dye should be like a cotton ball in the middle. It is not normal. It's leaking out through a tear in the back. You can see the herniation, the outline. Show us the outline of the herniation. Boom. Right. And that's what's hitting the nerves going down his legs. Are you better now? All right. Sorry about that. How bad is that on a scale of 1 to 10?
Give us a number.
How high does it go?
6.
Is that where you get back pain? All right. So 6 out of 10 at L4-3-4. And that is concordant. That's where he typically gets back pain. You see the disc is less painful, but if you look at the x-ray, it's got some dye leaking out. Show us the dye leaking right there. So the tear is not as big, so it's not as painful. So show us the 10 out of 10 tear. Henry, you see this? Big tear?
Yes,
10
we do.
out of 10 pain. Small tear, 6 out of 10 pain. Is that better? All right. We're almost done. I'm going to put you to sleep, okay? How bad is that on a scale of 1 to 10? That was a 10. Is that where you get back pain? Now, guess what? All that pain you just felt in all those places is going to be gone when you wake up. It'll be gone the rest of your life. Aren't you happy about that? All right.
Hands inside the ride.
Go ahead and count from 1 to 100 for us, nice and loud, so we can hear you. All right, so while he's counting, we're going to be putting him to sleep. We'll know when he's asleep because he'll stop counting, right? Unless you can count in your sleep. So you can see the discs have giant tears at 2, 3, and 4, 5. Smaller tear at 3, 4 in between. But we're going to fix it all. This should take care of his back pain and his leg symptoms for the rest of his life. Nice and loud. Count from 1 to 100. All right. We've lost now about, 2 cc's of blood maximum. About 40 drops of blood. So not a lot. The whole surgery is going to be pretty much bloodless. That's the blood we're going to lose right here. This is it, folks. That's blood for the whole surgery. That's like a nosebleed, right? So basically nosebleed, and if I did a fusion on this patient, which is the alternative surgery, this is the incision, literally this long. It's about 11 inches, 12 inches long. That's how big I'd have to cut them open. Henry, you've seen those laminectomy incisions.
Of course.
You want to show the audience? No, we don't want to gross them out.
Nah.
But basically, big incision, moving all the muscle and fascia over, exposing the spine, laminectomy, removing the bone and ligament, putting in cages at each disc, and then screws and rods holding everything together. That's what we used to do a long time ago. All right, let's get started. So what are we doing here, Luis? We're doing 4, 5, left side first?
Yes.
All right. Did you show the video of how the DLDR works?
Not yet.
Let's do that. Shot?
Copy that.
All right, welcome back. You can see the Deuk laser disc repair procedure is an endoscopic surgery done through this tube right here. Now I can tell you we're going to use the full length of this tube because he's got a very deep spine, a lot of soft tissues. But the whole surgery is done through that minimally invasive tube. And Dr. Berndes and I are working together to keep him comfortable as possible, yet still ventilating. Now he is a bit fidgety, but that's just, I think that's just reflexes, right?
Yeah.
It's not conscious. Yeah, he's great. I'm fine. All right, we're pushing everything in. I need to. So the dilator's going in and the tube. We need to pull them both back a little bit.
No, they're both in there.
Yeah, I know, but they're not supposed to be. What do you got? Shot? All right, so we got to advance the tube over the dilator. Shot? Yeah, it's better. But look at that tube. Isn't it sitting at the facet? Yeah, it is. Let's go ahead and take that off. So we've got a situation where we're trying to get the tube down over the dilator, but the tear is so big, it's not grabbing. Hold on. Yeah, they're both moving together. I may have to redo it. We may have to take it out. So we'll get the, oh, there we go. Shot. All right, let's pull the dilator back a little bit. So we're having a little technical thing here where the dilator is advancing along with the tube. We don't want that. We want the tube to slide over the dilator. Thank you. Luis? Shot? Good. There we go. So the idea is to get the tube to slide over the dilator. I think we're good. Take it out. And then you leave the tube and you take the dilator out. Once the dilator comes out, this was what was stuck inside the tube. You could see there's a little bit of disc material, and that kind of gets trapped between the outer sleeve tube and the dilator, and they move together as one. Don't worry, I got it. Yeah, I got it. It is. All right. Any questions, Henry?
No current questions.
Are we back yet?
Yes, we are.
All right. Thank you. All right, folks. We're starting on the left side. We're going to do the Deuk laser disc repair. That's the name of this surgery. You won't find it anywhere else in the world. It was developed here. It is the most advanced spine surgery in the world for eliminating back pain from a disc injury. Okay, we got to do this better because every time it's the same thing, it just does this. So you need a little more length when you wrap it so that I can have it stay over here. But it's just like I've seen it repeatedly, which means the technique is consistent. Your technique is consistent, but it's flawed. Does that make sense? So it's consistently flawed. So let's fix it. All right, so I'm in there grabbing and I felt a little snap. And guess what I'm feeling? I'm feeling the needle from the other side. Remember, we put 2 needles in this disc. I can feel the needle with the laser right there. So we're going to see that needle in just a moment. Any questions from our audience?
No current questions, but we do. AJ has a question, and he asks, what is that white stuff?
The white stuff is the herniation, AJ. And it's sitting inside the annular tear. It's got a faint blue stain. You see that? Some of it? That's the degenerated nucleus pulposus. That is the herniation. We are inside the herniation right now as we operate. And just underneath this little piece of herniation, you're going to see is the metal needle from the opposite side. Now, we don't want to zap the needle too much with the laser because it will melt it. And if we melt that needle, we won't be able to get the stylet out, which is the centerpiece. And then you won't be able to put the guide wire in, and then we won't be able to do the surgery. These are pieces of herniation I'm taking out right here. They've got a faint blue coloration. I just grabbed the needle again. It's underneath that little piece of tissue right there. We can see if we can see it. Once again, that's the needle from the right side, the opposite side. Because what we're doing here is we're fixing both sides on this disc. He's got herniations on both sides. By the way, the glass fiber you see there moving around, that is the laser fiber. And its purpose is to deliver laser energy and cavitation force to the tissue that we're trying to ablate. Remember, our purpose here is to remove this tissue. This is abnormal tissue. It shouldn't be here. It's causing all that pain and the leg symptoms, so we want to get rid of it. So Luis, the laser is working amazing. This is our new laser, a 60 watt actually. Look at the tear right there, guys. You see the tear? So on the left side, that is the annulus fibrosus torn. It's torn right in the middle. That is the annular tear. You see this as the first sign of injury to all disc problems. So whether you have a bulging disc, a herniated disc, a ruptured disc, a protruding disc, an extruding disc, a slipped disc, a degenerated disc, it doesn't matter what type of disc injury you have, it all starts with an annular tear, and I just showed that tear to you. The scope is a little blurry. I'm not sure why. But the purpose of our surgery is to clean this tear out, get rid of the herniation, the blue stuff right there. You see it stuck in the tear. The reason the herniation sticks to the annular tear is, remember, the herniation has no blood supply, the annulus does. And the blood supply brings inflammation. The inflammation causes scar tissue. And what's happening is the herniation is creating inflammation within the annular tear, and that's causing scar tissue to form. The scar tissue binds the pieces of herniation down to the annular tear. We're here to debride the herniated material, the blue stuff, out of the tear, and to clean the edges of the tear so that it will heal. We're also here to unpinch the nerve. All right, any questions?
Yes, we have a question from Bell on YouTube.
Hello, Bell on YouTube. Welcome to
They-
our live stream.
They asked, why isn't the rest of the world doing this, especially South Korea? You are doing multiple levels. I saw some surgeons unable to perform multiple levels with an endoscope. I understand fusions make more money, but in Korea, it's more of a societal-based healthcare system that isn't necessarily monetarily based.
Well, Bell, you are 100% correct. I agree. More surgeons should be doing this procedure, but it's very complicated. I don't know how to explain it, but it's a very complicated answer. I'll do my best. Basically, knowledge in medicine is typically passed on from institutions down to students. Students being medical students, and then above the medical students are the residents, interns and residents, and then of course they graduate and go on and practice medicine. The problem is the institutions, our educational institutions, have been infiltrated by the companies in the United States, by the companies that manufacture and sell and profit from metal, screws, rods, fusions, artificial discs. And see that blast, see that flare right there? That was the laser energy hitting the needle that's buried down there from the other side. Those flares, okay? I'm not going to do it again because every time it does, it means it's hitting the metal and it's probably melting a little bit. I don't want to melt it together, and then we won't be able to do the surgery on the other side. But in Korea, you're right. They became more advanced under the leadership of Dr. Sang-ho Lee, who was the first pioneer in Korea, South Korea, with endoscopic surgery. He's the one who is the president and founder of the Woodidal Hospital System. If you want to look it up, they now have, I think, 7 or 9 hospitals around the country. They service most of Asia. But again, I'm a private practice neurosurgeon. I just happen to be a very good private practice neurosurgeon, and people don't pay much attention to private practice neurosurgeons in the academic world. And the academic world is the world of universities and big business. They all commingle in the academic world. So I have become the black sheep, so to speak, because in the United States, they don't want this technology getting out. So they try to keep me marginalized and what I do marginalized. They don't want doctors, surgeons doing this treatment. They don't want doctors referring patients for this treatment because they're going to lose a lot of business, okay? So I've decided over the years, because I'm not here to make friends with the implant companies, I'm here, or the surgeons, I'm here to take care of patients. I made a commitment when I went into medicine to do what's best for the patients, my patients. And so that's what I do. I've left mainstream neurosurgery and spine surgery and pain management, and I've gone off and I've discovered treatments that actually work to cure pain. Unlike them, they want to just manage pain. They want you coming back. They don't want you cured. Because when you cure somebody of pain, then they're no longer a customer, and doctors are no longer making money off of them. But I found that you can make plenty of money if you do what's best for the patient, which is to cure their pain. And the other doctors really don't know how to cure the pain, even though I broadcast these videos every week. You think they would, right? You think they would watch and learn. But there's the needle on the other side. You guys see it right there?
Yes, we do.
I'm telling you, it's buried underneath the herniation. So I don't want to hit it too many more times, but you saw it look like lightning going off behind the clouds. That's the laser energy interacting with the metal. These lasers are extremely powerful, yet very safe, as these are the most powerful and safe lasers you can use in healthcare and medicine. It's It's called the holmium YAG laser, very best in the world. They're used by many different kinds of doctors, including kidney doctors. They use them to break up kidney stones. I use them to repair discs. They are FDA approved for disc repair. So we're using everything we do is FDA approved. But getting back to your question, I can't change the doctors of the world. There's too much motivation. They're too entrenched in their ideologies and beliefs and training. And they're in a system that makes sense for them. It makes money for them. It makes money for a lot of people, hospitals, implant companies, surgeons. And this would destroy all of that. This would destroy everything that's been built for the last 100 years with respect to spine surgery. This is literally the most disruptive technology ever brought to spine surgery and pain management. And they're not ready for it, you know, and they never will be. That's the inflammatory tissue right there, the pink stuff I just zapped. So for me to sit idly on the side and wait for them to adopt this technology before I treat patients is wrong. It's unethical. It's immoral. I don't believe that's the right course of action. I'm driven for purpose, a purpose to basically go out and do what I committed myself to doing many years ago, which is to help people with suffering and pain. I never really understood my purpose in life until I came here and I see what I'm doing and how different it is than what other doctors do. But I can't fix the whole system. Not yet, not today. You guys can fix the system. I can't do it alone. People have to change. People have to make the change occur. Change can be good. You know, survival of the fittest, evolution, Darwinian principles. It's part of life. It's part of our universe. We have to accept it. This is the change in spine. Except the animals that are going to go extinct, they don't want to go extinct. They're going to fight tooth and nail not to go extinct. And that's what's happening. Okay? Pure and simple. This is evolutionary pressure at its finest. Great questions, though.
We have a couple more questions.
Sure. I'm almost done with this disc, by the way. This is the end of the disc. You see the fat right there? That's fat around the nerve root. So the nerve root is just outside there. Look at the pink tissue. That's the inflammatory tissue, granulation tissue that we see every time. And it is the pain source for this patient. The pain generator is the disc, but the real pain generator is the inflammatory tissue right here. This is going to be the most painful area of his entire disc. The one that causes the most back pain and leg symptoms. We've cleaned it up pretty darn good. Just about done with this one. All right, I'll take the question.
This next question comes from Josh on YouTube. And
Hi, Josh.
they ask, how much does a procedure like this cost? I know this is a question everybody's wanting to know.
Well, Josh, it depends on how many discs we're fixing and how many facets we're fixing and how many sides we're operating on and what part of your spine your disc is in, because some areas are easier to fix and take less time and effort and resources, basically. Other types of discs take more time, more resources, and more effort. So it depends on what we're doing, on how many sides, how many levels, before we could tell you. The best thing to do, and I tell everybody this, is get a free MRI review. You'll meet me. The most important thing is I need to know what's causing your symptoms. And that can't be determined from an MRI alone. I must examine the patient. I must see you on Zoom. I must see where your pain is. I must correlate the pain to the MRI. It is impossible for me to be able to eliminate your pain without knowing where it's coming from. And the MRI never tells doctors where pain comes from, never. There's not a single MRI in the world that has ever told a doctor where the pain is coming from. Now, there are some situations that make it easier for the doctor. For example, if you have a tumor in your spine, everything else is normal, but the tumor is destroying your spine. Well, that's the source of back pain, right? The tumor. Or if you had an infection, or if you had a new fracture in your spine, that's probably the source of pain. But we're not dealing with tumors, fractures, and infections. We're dealing with basically arthritis, inflammation, and you can't see inflammation on an MRI too well. So I need to do an exam. I do this for free. It's our free MRI review. And Henry will put the link in the dialog box right now. You're welcome to get my free MRI review with me. And at the end, I'll tell you exactly what needs to be done. Then my team of schedulers will contact you. They'll look at your insurance. They'll look at your procedure, how many levels we're doing, how many discs, which levels, which sides. Are we adding facets? Are we adding the SI joint? And they will price it out for you. So it really depends on the individual. All right, we're done with this disc. Remember, we're on the left side. So the nerve root is going to be on the right side here. Just a moment, I'm going to finish. This is still part of the herniation. If you're an endoscopic transforaminal surgeon like me, make sure you look laterally before you finish your surgery, because you may be surprised to find a lot of herniation right over here on the opposite side. So this is in the foramen, basically a foraminal and extraforaminal herniation. All right, good. The nerve root's going to be right there in that fat. You can see the defect in the annulus right now. It's skinnier than the whole of my tube. See, my tube is around 5 millimeters across. This glass fiber is 1 millimeter. So it's really around 1, 2, 3 millimeters from side to side. Okay? But that's it. Now his back pain from that disc from this side is going to be gone. So scope is out. I'm going to irrigate with a little bit of betadine, a little more dilute than that, please. And then we're going to remove the tube and move on to the next disc. We've got 5 spots to fix. After we're done with fixing this, we're going to fix his facet joints, because he has pain in his facet joints as well. So we've got a long surgery ahead of us. He'll take the full 2 hours. When I put the irrigation in, I have to remove it, and that's what the dilator is for. Right? It's called displacement. You know, when you put a new boat in the water, it displaces the water, right, with its hull. Where's my roll? You got to have the roll ready, okay? Got to do your job to help me help the patient. All right, 1 down. Bring the fluoro in. We're going to bring our x-ray machine back so we can use it to navigate. And next we're going to do the, oh, great. Shot? I think this came out. I think the needle may have been pulled out with when I took the tube out or something. So I'm going to have to use the x-ray machine to relocate it. All right, so it did pull back a little bit, but we're still close. Shot? There, it's in. All right. So at this point, we're going to put our guide wire, remove the needle. Shot? Uh-huh. Shot? I'm just anchoring the guide wire in there. Hold pressure here, right here. Yep. Taking out the needle, leaving the guide wire. Shot. How's his blood pressure? I'm going to give some more numbing medicine. It's always good that what hurts people after surgeries like this is their muscles. And the numbing medicine helps that a little bit, but it's not going to prevent the muscles from hurting entirely. And the reason for that is shot because the reality is the muscles hurt because of some of the blood that's in there, and the blood will break down over the next few months. And when the blood breaks down, it actually irritates the muscles very badly. It causes inflammation. Shot? So the more we can prevent the blood from staying in the muscle, which is impossible to do 100%, but you want to try to do as much as you can. But if you can, hold on, if you can minimize the amount of blood that goes in the muscle after surgery, and this is for any surgery, by the way, not just our laser surgery. That's the biggest problem with fusion surgeries, laminectomies, is the muscles are really badly hurt during the surgery. In our case, we're not hurting the muscle, we're just irritating it with the blood. But in other open surgeries, the muscles are destroyed. You can see it on MRIs taken after surgery. You can see all the dead muscle. Not this surgery I'm talking about laminectomy, discectomy. Tell me what you need me to do. All right. The first what? Oh, so you mean putting the tube in causes a little vasovagal? Well, let's keep them safe. Whatever we need to do, you tell me. Hold pressure here. Yep, good job. All right. So you can keep him lighter if you need to, Dr. B. Whatever you think is best. I don't mind him moving a little bit, fidgeting a little. It's fine. I mean, any more questions, Henry?
Yes, we have a couple more questions. Next one comes from Brooke on Facebook.
Hello, Brooke. Welcome.
They said, I'm just joining in. What procedure are you doing?
This is the patient with back pain. We're fixing his back pain. So, Deuk Spine Institute, by the way, there's the needle from the other side. You see it? Deuk Spine Institute, who you're watching right now do a live surgery, is the first in the world to discover the actual causes of back pain and, more importantly, develop treatments to eliminate back pain. Same goes for the neck. If you rewind the surgery, you'll see that we have figured out where back pain comes from, and we treat the sources of back pain with specific treatments designed to permanently fix those sources. This is one of those treatments. It's called the Deuk laser disc repair. It turns out that 85% of back pain comes from an injured disc. You know those names as herniated disc, bulging disc, ruptured disc, protruded disc, extruded disc, degenerated disc. All those names, slip disc, they're all the same thing. It's an annular tear and a herniation. And it's the inflammation in the back of the disc that causes all the back pain. We're the first in the world at Deuk Spine Institute to identify the source of back pain and to develop a treatment specific to that source, which is what you're watching right now. So we are fixing this patient from New York who's traveled here to Florida to have his back pain eliminated. And it's going to require that we fix 5 spots on his back. And we're going to have to fix 6 facet joints, because the second most common cause of chronic back pain is facet joint pain. The facet joints are small joints located in the back of the spine, behind the disc, just behind the disc on the sides. So if the pain is coming from a disc, we do the Deuk laser disc repair, which is what you're watching right now. If the pain is coming from the facet joints, we do the Deuk plasma rhizotomy, which we developed here as well. Both of them are minimally invasive, outpatient procedures, and it so happens that we're doing both in this patient from New York to get rid of his pain, because his pain is coming from 4 facet joints on the right side, 2 on the left, and 3 discs that we have to fix. He also has leg pain, neurogenic claudication. We're fixing that as well. Thank you. Great question. Thanks for joining us. So you're watching live spine surgery happening right here, right now, and you can ask questions, and I'll answer them for you while I'm operating and teaching you. All right, we're just about done with this disc. This was a quicker disc. It's an L2-3 disc. One thing I almost did as a no-no, I almost turned on the laser while I was inside the scope. Luis, I think his sphincter tone just increased 100% as he's watching me hit the pedal, not seeing the laser. You always want to see the laser fiber is actually outside the scope. What will happen is if you turn the laser on inside the endoscope, it'll blast the lenses apart, and then you'll lose your lenses. And then you'll have to send the scope in for repairs, about $5,000 just to repair it, which sucks, and we try to keep costs down, but these are very expensive tools, and they are very hard to come by. So these are made in Germany. They're all FDA approved. But yeah. Anyway, any more questions?
Yes, we have a couple more questions. This next one comes from B3 on YouTube.
Welcome back, B3.
They said, I was told laser isn't necessary if the procedure gets most materials. Is this the case, or is it just that the procedure becomes more expensive?
Oh, that's a tough question. I'm not sure I understand the question. Something about I was told laser is not necessary. The only people that tell you laser is not necessary are doctors who don't do laser, because they don't want you to go get fixed. And by the way, this is not any laser surgery. This is the Deuk laser disc repair. It happens to use a laser, but it also uses an endoscope. The most important thing we're doing here is what's called an annular debridement. It's the annular debridement I'm doing right now with the laser that is what gets rid of the back pain and the leg pain. So whoever told you laser is not necessary, it would not be here at Deuk Spine, unless of course it was me, in which case maybe laser is not necessary if you have some other thing causing your problem. But don't believe what you hear from other people. It's one of the things we try to teach people out there is that you can't trust all the doctors. They're not all good. They don't all have your best interest at heart. Many of them are out there to turn a profit, and many of them want you suffering in pain because that's how they make money, is when you keep coming back. We're not interested in bringing our patients back. We're interested in fixing them and never seeing them again. So that's what the patients want, that's what we want. That's why we do that. Most doctors that treat back pain, they all want you to keep coming back because that's how they make their money. So if you're cured of back pain with the laser surgery that we're doing here, they're out of business. I hope you understand the economics. But we're more interested in curing people, and we have no shortage of patients to cure. If you look at our YouTube channel, you'll see we have hundreds upon hundreds of patients we've cured of pain. And they're all very happy. And that's what we want, happy patients. All right, we're done here. 2 down, 3 to go, as long as I have the okay from my anesthesiologist. We're good? Keep the questions coming. Do what? Yeah, whatever you need me to do, I'll do for you. Sure. How long does a glycopyrrolate stay in? A couple minutes. Okay, keep the questions coming, folks.
This next question comes from Bell, once more on YouTube.
Hello, Bill.
They ask, thanks for being a pioneer, but that being said, does Cigna or any other insurance cover this procedure?
Great question. Yes, we do get insurance coverage. Not all insurances will cover it. And when you mention Cigna, some of their plans will cover it, others will not. It just depends on how good your plan is. If you have a really good insurance plan, they'll cover the surgery. If you don't, you have a cheapo plan, they're not going to cover it probably. Because cheapo plans are cheap not because they don't exclude surgeries, they just deny surgeries, they deny treatment. But they're a cheap plan because they want to spend less money on you. In other words, cheap plans make money by denying treatments, whether it's the laser surgery, whether it's prostate surgery, whether it's, I don't know, C-sections. I mean, take your pick. Insurance companies deny things all the time. So when you ask, is it covered, I can't tell you yes or no. If I say yes, I would be, you know, it is covered, but not all the time. And if I say no, it is covered, but not all the time. So the answer turns out to be, it just depends on your insurance plan. If you have a really good insurance plan, it'll be covered. If you don't, it won't. And if it's not, then we're going to have to help you fight to get your insurance to pay it. Yeah, so we get a lot of questions like that. And the reality is that we've been paid 100% by Cigna, by United Healthcare, by Aetna, by Humana, by TRICARE, but it's not consistent. We don't have consistent payments where they're doing it all the time. And the reason is we don't have a contract here. Huh? Just wait? Slower? So tell me what to do. Just. Yeah? All right. Great questions, by the way. I love the questions. Hold on. Let me see. Shot. I think we're okay. Go ahead. Yeah? So vasovagal, what do you see? The heart rate will drop?
It drops about 30, 20.
I'm in now. Is that okay?
Yep.
All right.
Just making some changes because
Yeah, I know. I love it.
didn't improve, so now we're going to improve.
Evolution. Right? Evolution. You have to respond to the environment.
Same thing, expect a different result.
That's right.
I wouldn't go that far.
So we showed up to work today and we had some devils here waiting for me. I'm just kidding. They were my staff. They were dressed in Halloween costumes. Today is Halloween. And we encourage celebration. You want me to hit you? No, you sure? Oh, come on, Luis. I have so much fun hitting you. We're getting a lot of cold welding today, unfortunately. Here, let me see if I can help you. Let's put a. So what's happened is there's some disc material that's stuck between the tube and the dilator, the sheath and the dilator, and it's not letting me or Luis get it out. Yeah, no, it's stuck together. Yeah, shot. Yeah, they're both coming out, I think. Right? Or am I getting it? No, I got it. Yeah, all right. We'll keep going here. Let me have the other thing maybe. Get it on there. So we're just playing a little MacGyver here. This is not normal that it happens. It happens 10% of the time, but we have a strategy for dealing with it that involves different strategies actually. There we go. It's coming. All right, we got it. So we use this special grabber from the company, and we were able to take the dilator out, leave the tube in, so we can get the surgery done. Any questions from our audience?
Yes. This next question comes from Premier Media Group on YouTube.
Welcome. Good to have you back.
They said, good morning. How much long-term damage does prolonged guarding and gait modification do you complementary joints and systems? Does chronic and severe lumbar pain possibly trigger knee joint damage?
Yeah. You are correct. I'm so happy you talked about that. So the question from Premier Media Group, who always asks good questions, is if you don't fix your back like we're doing right now, and unpinch the nerves or even fix the back pain, how much damage can happen to other parts of your body like knees and hips, buttocks, pelvis, because you're not fixing it and you're walking bad and standing bad? A lot. We see it a lot. Listen, folks, if you have a herniated disc, bulging disc, degenerated disc, you're having back pain, or you have a pinched nerve, come to Deuk Spine Institute. Get it fixed right away. If you don't, you're going to end up favoring one side or the other. You're going to walk funny, you're going to stand funny, or you're also going to become deconditioned, right? You're just going to want to take it easy and sit around the couch, rest your back. That's not how human beings were meant to be, you know, living their days. We're supposed to be active. We're supposed to be moving around. My wife always tells me when I come home at the end of a long day and I plop onto the couch to watch a movie, she always says, "You should get up and exercise." And I said, "I'm too tired." And she says, "Movement is life." And she's right. Movement is life. So when you're suffering with back pain, leg pain, and you are not getting up and moving around normally, you know, you're basically robbing yourself out of the quality of your life, but you're also adding additional risks like diabetes, high blood pressure, you know, muscular degeneration and atrophy, hips, knees go bad because you're favoring one side versus another. Everything okay? So, long story short, don't put off getting your spine fixed at the Deuk Spine Institute. It's safe. We take great care of the patients here. We don't have complications very often. It's extremely rare. It's a very safe surgery. It's pretty much bloodless. I mean, you could see we lose a few cc's of blood, like a nosebleed amount. But there's no hospitalization. You're going to go home the same day. And basically, you go back to your hotel. We see you in the next morning, and then you can go back home, wherever you're from. We have a lot of people from other countries, other states. 80% of our surgeries now are people out of state. We're almost done here with this disc. You can see all the herniation coming out. You see that? That's a herniation. It just popped out from the tear. That's because of the laser. Great question. Don't put off getting your back fixed. Don't live with chronic back pain, neck pain. We can fix it now at Deuk Spine Institute. Come here. It's worth the trip. You want to go see the Eiffel Tower? You go to Paris. You want to go see Mickey Mouse? You go to Orlando or Disney World, okay? If you want to get your back and neck fixed properly, you come to Deuk Spine Institute. It's that simple. By the way, you can see Mickey Mouse too while you're here. Huh? Kill two birds with one stone. Right, we're just 45 minutes from Disney World. And the new Deuk Spine Institute is opening in Orlando next year in December. We'll be right near Universal Studios. If you like roller coasters, they have what I think is the best roller coaster right now in the world. It's called Velocicoaster. My wife and I literally, when we're on the weekend, we'll hop on our bikes. We'll bike 30 minutes. We'll be in Orlando at Islands of Adventure and Universal Studios. We'll literally knock little kids over on our way, like running to the Velocicoaster to get in line, do a quick ride, and then head home. But no, we love doing that. Luis does it too, right, Luis? Last time I saw Luis in Orlando, he was at a Gypsy Kings concert with me. We both love the Gypsy Kings. I'm not talking about Tyson Fury. I'm talking about the real Gypsy Kings, the original Gypsy King. You got to pinch it. All right, any more questions?
Yes, we have a couple more questions. This next one comes from Giannis once more on YouTube. And they asked, can you do surgery on the cervical spine and the lumbar spine in the same surgery?
Yeah, great question. Can we do surgery on the cervical spine and lumbar spine in the same surgery? The answer is yes, we can, if we're doing the Deuk plasma rhizotomy for facet problems. But we cannot do the disc surgery on both parts in the same surgery. In other words, if it's a disc problem and we're doing the Deuk laser disc repair, we cannot do both. Cervical and lumbar, same surgery. We can do one on Tuesday, one on Thursday. On the other hand, if it's your facet joints we're fixing, then yes, we can do both. So it all depends on what procedure you're having done, which is of course determined by what is your diagnosis for the source of your pain. And that requires me to figure that out. Great question. Just about done with this one. Keep an eye on these other needles, okay? I don't want them coming out. Like this one's already come out a bit. You cannot let these come out. Hey, that's your job, is to watch those needles. You're not watching them. You're not, I'm turning this. You got to hold them in. Okay? We're almost done here, yeah. Just about 2 minutes, we'll be done. And then we'll be off to the... Oh, look at the herniation right there. It just came out of the annular tear. You all see that? If you haven't, rewind it. You'll see it literally just like a grumpy man getting out of bed. It just poked its head out from between the sheets of the annulus. That is a herniation, folks. Stuck inside the annular tear, causing inflammation. Look at all the scar tissue. All that golden orange stuff around it. That's scar tissue. The only way you get scar tissue on you is if you cause inflammation. You know what I mean? It's kind of like a little kid going in the kitchen and getting in the cookie jar. They come out with cookie crumbs all over their face and chocolate on their hands. You know they've been in the cookie jar. So I can say that this is a inflammation here, a herniation with inflammation, because I see the evidence on the herniation, just like you see chocolate chip and chocolate sauce on those fingers and mouth. Watch the needles. Come on. Don't make me tell you 5 times. By the way, I am somewhat brutal with my staff when I have to tell them more than once to do something. Some people don't like that, but we're in healthcare. We're operating on someone's spine. Somebody makes a mistake because they're not paying attention, they're lackadaisical. Guess who pays the price? The patient. And I don't want my patient suffering because of my staff's stupidity. That's one thing I will never accept. I'd rather lose my staff than have a patient get hurt because of their not paying attention, doing what they're supposed to do. All right. Any questions?
Yes, so our next question comes from Josh, once more on YouTube.
All right, Josh.
And they asked...
Wait, before you say anything, look at the pink tissue, guys and gals. You guys see the pink color? That's where the pain is coming from. That's inflammation. See how nicely the laser gets rid of it? There's no other tool in the world that does that, like the laser. The laser is the only way, the Holmium YAG laser at Deuk Spine. All right, sorry.
This question from Josh, they ask, can this procedure be used for spinal stenosis?
Yes.
Like hypertrophy of the ligamentum flavum? And could you explain bilateral nerve root and enfacement, please?
Yeah, Josh. So the ligamentous hypertrophy you're talking about causing spinal stenosis, it's not really the ligament causing spinal stenosis. It's actually the disc that's causing spinal stenosis the most. And if you go in and you take the ligament out from the back, you're not really treating the spinal stenosis. You may get a slight improvement, patients may get some temporary improvement, but you're not fixing the real source of stenosis, which is the disc. So laminectomy, which treats the ligamentous hypertrophy you're talking about, if you get the ligament and you remove it, it never treats it properly because it only takes half of the thickened ligament out, and that's the half that's closest to where the surgeon's operating. The other half that's in the foramen is the #1 reason people have failed back surgery. So going after the hypertrophied ligamentum flavum is the wrong approach. At best, it's partial improvement in leg symptoms, and at best, it's partial improvement for just a few years at most. Then symptoms come back. It's called restenosis. So we don't do that. We don't go after the ligament. It's unnecessary, and it never fixes the problem. If we don't go after it and we go after the disc like we are here, then we can get rid of the leg symptoms 100% of the time. Not 50% improvement like you get with a laminectomy removing the ligament. So going after the ligament is very ineffective. We don't do it here. Can we do it? Yes. Very easy. I could drill away the facet. I can also remove ligament. But I don't do it. Because when you start taking ligament out, you're going to cause more scar tissue and more bleeding. It's unavoidable. There's no way to remove the thickened ligament without causing really a lot of bleeding and a lot of scar tissue. So we don't do it. It also doesn't work. It doesn't take patient symptoms away. And more importantly, we have a better way to fix the problem right here that you're seeing with the laser on the disc. Great question. Thank you for asking that. All right, just about done. There was a little more herniation than I anticipated, more scar tissue than I anticipated from the inflammation. Keep the questions coming, folks. Happy to answer them.
No,
Yeah. By the way, a lot of doctors will try to sell you on their surgeries by showing you things on the MRI and telling you that's what's causing the problem, when it really isn't. The proof is in the pudding. What you want to know is what's their results. And at Deuk Spine Institute, our elimination of back pain from a herniated disc is 100%. We've never had a single patient that we did this procedure on that had disc pain that we did not get rid of their disc pain. Now, there are patients that have other causes of pain besides their disc. And, you know, this surgery will not get rid of anything other than disc pain, because that's it. We're just operating on the disc. We're not operating on anything else. Go ahead.
Next question comes from B3 once more on YouTube. They ask, can you do the annular removal with just grabbers through the endoscope without using the laser?
Yeah. You cannot do the annular debridement. We're not doing an annular removal. We're not touching the normal annulus. We're not removing the normal annulus. We're not doing an annular removal. I don't know who told you we were. We're doing an annular debridement. It's very different. A debridement is when you remove abnormal tissue, not when you remove normal tissue. If you did an annular removal, you're removing the annulus. You need the annulus. That's normal. So we're doing an annular debridement, which is removing abnormal tissue. Can you do it with the grabbers only? Absolutely not. It doesn't work. You need the laser. The laser is the most important tool in this surgery. If I had one tool and one tool only, and I wanted to have the best results for the patient, get rid of their pain, the laser is the one tool I would have. There's no other tool in medicine that is better than the laser for this application. Now, for facet joints, I would not use the laser. We tried using the laser for facet joints, and it doesn't work. I mean, it works, but it's a pain in the butt, and it takes forever. But there's a better way to do that, and that's the Deuk plasma rhizotomy. So we tried the laser, but we were very unhappy with the results. All right, so let's see. There's a nerve right there. You guys see the white thing underneath that cobweb? That is the nerve root.
Yes,
now,
we do.
when we're done, the tear, again, is about 3.5 millimeters, maybe 3.5 millimeters on this side. And it will heal. Laser on. It just takes time to heal. Healing is not something we can speed up for the patient. There's a lot of doctors that will try to sell you on things to heal the annulus, like the barricade device or disc seal. They don't work. They don't work, folks. It just doesn't work. We've seen it hundreds of times. It never works. All right, done with this one. If those procedures work, we'd be doing them. They're really easy to do. Technically very, very easy to do. but they don't work. That's why we don't do it. Deuk Spine Institute does not do treatments that don't work, that don't cure pain. I mean, we do some shots and stuff to kind of hold people over till they get their surgery that's curative, but in general, we don't recommend treatments that are non-curative. After all, would you want your cancer just knocked down with chemotherapy and radiation, or would you want your cancer cured? I would want mine cured, just like I'd want my back pain cured. I don't want to just get treatments, keep coming back and having to keep treat. I want a cure. All right, questions? Move.
Next question comes from
Now.
Ali on
Go ahead,
Facebook.
bring it in, Jordan. Yes, Ali.
They ask, in typical microdiscectomy, do they sometimes pinch off the annulus accidentally?
Great question. So do we have our microdiscectomy video we can show?
Let me check.
If not, move it over during the break.
Oh, I believe we do. Yep.
Let's run the microdiscectomy video. But
Okay.
to answer your question, with a microdiscectomy, the problem is the surgeon is only removing some of the herniation that's sticking out. They don't actually debride. No, don't go over there. Don't go over there. That's not sterile up there. Just stay down here. Yeah. In a microdiscectomy, the surgeon is not actually debriding the annular tear. That's one of the biggest differences between the Deuk laser disc repair and a microdiscectomy, is we are cleaning the tear so it heals. With a microdiscectomy, there's no debridement of the tear. Therefore, the tear will not heal. Therefore, you will get a reherniation quite easily. It's very common. Plus, your back pain won't go away. With a microdiscectomy, they don't do the annular debridement. Therefore, the back pain doesn't go away. The purpose of a microdiscectomy is to eliminate pain in your leg, or weakness, numbness, tingling in your leg. It is not to get rid of back pain. No surgeon on earth is going to tell you microdiscectomy will get rid of your back pain. I mean, if they do, they're lying to you. That's because we don't do microdiscectomy to get rid of back pain. We do it to get rid of leg pain and weakness in your leg from a pinched nerve. So it's very important to understand that difference. The Deuk laser disc repair cures back pain and leg symptoms. Microdiscectomy, 50% improvement in leg symptoms, not cure. And it's temporary. All right, welcome back. We're starting on disc number 4 out of 5. We have one more disc to go after this. Then we're going to end this broadcast. We're going to switch over to the Deuk plasma rhizotomy, which is to treat facet joints. Remember, this Deuk laser disc repair is to treat discs. The Deuk plasma rhizotomy is to treat facets. And the discs and facets are responsible for 95% of people's chronic back pain People come here, folks, not just for leg pain. They come here because they want to get rid of their back pain. And that's one of the biggest differences about Deuk Spine Institute's treatment is we actually can cure back pain. Other doctors cannot. Other doctors will tell you that they can do, 50-50 chance of having improvement. We don't give you a 50-50 chance of having improvement. We're going to give you a 100% chance of having improvement. Just the question is, how much improvement are you going to get? And the answer is, on average, our patients get 98% of their preoperative back pain gone with the surgery. That is back pain coming from the discs, right? Not the piriformis muscles, not the facet joints. Those are a different source of back pain. And if you're having your facets treated at the same time, that's fine. You'll get improvement with that, right? That pain will go away. But you've got to treat all the back pain sources to get rid of all the back pain. And that's something that's sort of new, that most people have never heard that before. It's foreign to them because we never knew that. Literally, we discovered this at Deuk Spine Institute, all the sources of back pain. And we're going to be publishing it very soon in several places. One of them is our website. Our new website is going to be launched January 1st, and it's going to have incredible content that is going to be highly educational for people like you watching, wanting answers, wanting to understand what's going on, why am I having pain. I'm doing my best with it. I'm sure it's not perfect, but it's pretty darn good. Watch the needle. There's the tear right there. You guys see the tear? Looking left, you see the annulus torn right there. And in the middle, the blue stuff is the herniated disc that's staining blue. And then you got the annulus on the right side. And look at some of the herniation just stuck inside that tear. And look at the pink stuff. You guys see the pink color? It's very faint, but it's like a faint pink. That is the interposed herniation. That's what Deuk Spine identified as a source of back pain back in 2008. We've been talking about this since 2008, folks. Crazy, huh? That it's taken this long for people to start learning the truth. That's how small our voice is. Unfortunately, we don't have a big marketing budget. We don't spend a lot of money on advertising and marketing. We just pretty much word of mouth, and it's getting out there, and we do these broadcasts so people can learn. All right, what questions can I answer for the audience, Henry?
We have two questions. This first one comes from Josh once more on YouTube. They ask, can you explain bilateral nerve root effacement?
Sure. Yeah, so you're reading from an MRI report probably. What bilateral nerve root effacement is, the nerve roots come out of your spine and go down your leg or arm. They travel through a hole called the neuroforamen behind the disc. So if your disc is normal, your nerve roots are always going to be untouched. But when you have a herniated disc that's bulging out backwards towards the nerve roots can become, the herniated disc can start to interact with the nerve roots, right? And effacement means the herniated disc or bone spur, whatever it is starting to touch your nerve roots. And it shouldn't be. Effacement means it's touching it and starting to get in the face. It's like in your face, mother. So, just a little humor there, or at least my attempt at it. But effacement means that the nerve roots are being touched and even maybe slightly compressed by whatever it is that's effacing them. Most commonly the herniated disc. So it's a sign that the nerve roots are getting pinched. You're going to want to get that taken care of. This is the perfect surgery for that problem. Great question.
We have two more questions.
You guys see the tear right there, right?
Yes, we do.
And it's full of scar tissue, which is the kind of whitish, thick stuff. Like this is all scar tissue, and you can see the kind of pink color right there on the scar tissue. That's granulation tissue. It's a special type of inflammatory tissue. It's got lots of little nerve fibers. It's really painful stuff. It's kind of like a pimple. When you put your finger on your pimple and you push on it, it hurts. That pressure hurts it. That's why his discogram was positive, is that pink stuff. Got the pressure. All right, I'll take the questions.
These next two questions come from Ali, once more on Facebook. And this first question is it possible to know you also have facet pain going on, or does this need official diagnosis?
It's hard to tell, Ali, but you have to have an official diagnosis. You're not going to be able to tell on your own. You need an expert to tell, and sometimes they have to do treatments or tests in order to figure it out.
And their next question is, if a person has many annular tears that you debride, like both sides and or diffuse, is their healing process a bit more fragile?
No. No, it doesn't matter how many annular tears you have. They all start healing immediately after the surgery. So whether you have one or you have five, the healing clock starts the same time for all of them, and it takes the same amount of time. I always tell everybody it takes 1 year for that tear to completely heal and be strong. So you got to take it easy your first year and not re-injure it. We do have people that re-herniate discs even after the surgery. Even after we tell them to avoid activities, they don't listen. They think that they're different, that they can get away with it for some reason. I don't know why, but they do. It's always happens, human nature. I mean, I'm the same way, let's face it. I don't listen to the doctor all the time. And so, you know, you're gambling. But if you really want to be sure not to have a reherniation, you just take it easy that first year. Nothing strenuous. The kind of people who reherniate are always reherniating something heavy lifting something heavy like 50 pounds or more. They are doing, sports or things that make them bend over at the waist when they're not supposed to bend over. But those are our two restrictions, lifting and bending. And if you follow those restrictions, then you're not going to reherniate, period. But the people who reherniate, they're tempting fate. It's like anything with patients. You can always tell them, but they don't always listen. Our reherniation rate is 1%, by the way. We've had just about 1,800 surgeries now, and we've had 18 reherniations on the laser surgeries. I looked at our numbers, by the way. We've done 300 laser surgeries this year, since January 1st, and we're not even done with the year yet.
Is that a record?
Yeah. That's a record. Yes, thank you, Dr. Berndes, for pointing that out. You were part of that record. See, that's what happens when you have great anesthesiology, great team, great schedulers. Everybody's doing their job well. We get to help more people. 307. This makes 308 so far year to date. Just this year.
Normally you do about, 250 a year?
Oh, no. Before you came along, I was doing about 150 maybe. So we've doubled our volume. And, yeah. I mean, my goal is to do more than that. I want to help as many people as will come and get helped without us being the reason that we're limited. You know what I mean? We should never be the reason that we're limited. All right, just about done here, 10 seconds, and we're finished with this disc. Very good. All right, all done. Let me take a look at the nerve. Actually, there's a little bit of herniation right there. So I was looking north. We call it rostral, towards the head, and I saw that little bump. It's probably not going to do anything, but we're here. Might as well get rid of it while we're here. And that brings up another important point. People think that these surgeries get rid of all their herniation, all their spine problems. It doesn't. Our surgeries are not done on a macroscopic level. You're not going to see the changes necessarily on an MRI. Your MRI will look the same before and after. But your spine is not going to feel the same. You're going to feel much better. The pain's going to be gone. So this is such a minor, small area we're operating on, the MRI can't pick up on it, right? I mean, if you think about it, the MRI is capturing all this information. So to pick up on a tiny little 3 millimeter area of your back in your disc, it just doesn't have the resolution to do that. So I always tell people, don't expect your MRI to look normal after surgery. It won't. And the other thing is, the surgery will never get rid of 100% of your herniation. Typically, we'll get around 60%, and 60% is more than enough to get rid of back pain and leg symptoms permanently. You really need about 50%, and we always hit 50%. We've never not had 50%. That's why all of our patients have had success with the surgery. But you don't need 100, that's for sure. There's a lot of misinformation out there, and I don't blame people for having these preconceived notions about how it should be. But once you've had an opportunity to get educated, then that's when you really need to use your education and your knowledge to make good decisions for yourself. All right, questions? Last disc. We'll be done in 15 minutes. And then we're going to end this broadcast. So get your questions out. We're going to go on to our second procedure, which is the Deuk plasma rhizotomy to treat his facet joint pain.
Next question comes from Janice, once more on YouTube.
Sure.
They ask, can you explain to me what retrolisthesis, lordosis, and subluxation means?
Sure. You're reading your MRI report. Retro means backwards, listhese means slip. It's all Latin. Retrolisthesis means to slip backwards. And what they're referring to is your bones, one bone relative to another. So they would have said like L4, L5 retrolisthesis. So what they're saying is the L4 bone is slipping backwards on the L5, for example. And then lordosis is the normal curve of the lower back. Okay, it's curved backwards towards, the back, obviously. That's called lordosis. Where's the num-num? Num-num? And then the last one was shot. So he's got pretty vascular muscles. We're giving him a lot of numbing, but you can see he's got some veins in there that are bleeding a little bit. Not a big deal, but he is going to have pain in his muscles afterwards. There's no doubt about it. The more you bleed in your muscles during the surgery, the more pain you're going to have in the muscles. It usually takes a few months for that pain to completely go away. Shot? All right, almost done. And then I forgot what the last deformity was. They had retrolisthesis, lordosis, subluxation.
Yes,
right?
correct.
So subluxation means to slide downwards, basically, or slide over. And typically what's subluxing is facet joints. They sublux the most, but you can also have an implant put in your spine by a surgeon that subluxes. That you really don't want that, but that does happen with cages. Cages sublux. All right, let's see what we got here. Shot? Beautiful. All right. I gave him a lot of numbing medicine. You want me to hold up? This is our last one. Sure. Take your time. Yeah, we're almost done. And then we'll switch over to the facet joints. All right, what other questions do you guys have?
Next question comes from Ali, once more on Facebook.
All right, Allie.
They asked, after a year of healing, can I go back to whipping my hair to dance?
Yes. Yes, you can, Allie.
Next.
After a year of healing, you can do whatever you want to do. And that applies for anybody having the Deuk laser disc repair. It takes 1 year to completely heal from the surgery. Now, if you re-injure your disc in that first year, then of course it won't heal. So you got to make sure it heals. And that's why we give you restrictions. The restrictions are the best chance of healing that annulus without any kind of reherniation. Little pressure here. Okay, so far so good. We've lost probably 10 cc's of blood on him. It's a lot more than normal, but it's still 10 cc's is very little blood. Hey, how come I can't see the scope, guys? Ah, turn the light on. Thank you. that always helps. Having the light helps. All right, any other questions?
Yes, this next question comes from Premier Media Group.
Yep.
Question to both Dr. Deuk and Dr. Berndes.
First name basis.
My biggest anxiety is probably excavative discogram. Can you give me any tips to help out with that?
Well, I mean, if you told me you don't want me to do your discogram while you're awake, then I won't do it. I'll put you out and we'll do it while you're asleep. So you don't have to, remember it or experience it consciously. But, in the end, we need this blue stuff. You see how important the blue stuff is? It helps me. And the way I get the blue stuff in your disc is through the discogram. So if I don't do the discogram, I can't get the blue stuff in here. So the discogram has to be done, but we can do it with you asleep if you prefer. That's up to you. But then you'll never know how much pain those discs that we're fixing are causing.
But then we get a lot of people that watch videos before the surgery.
Uh-huh.
They tell me in the recovery room, wow, that discogram was nothing. I shouldn't even worry about it.
Yeah, we've never had anybody complain about the discogram, by the way. And the reason for that is they don't remember. And that's because we give them forgetful medicine. Yeah. And if there's other things you don't want to remember, like, for example, your boss, your job, your spouse, we do charge extra. Right, Dr. Berndes? Just kidding. But generally, you're not going to remember the surgery. That's part of anesthesia.
It's the balance between amnesia and analgesia.
Yeah.
So no memory.
Yep. Dr. Berndes says it's a fine balance between analgesia, which is pain, no pain, and amnesia, which is no memory. But anesthesia is also no consciousness. You're not supposed to be conscious of what's going on. But obviously, the kind of anesthesia we do, where it's twilight, you're kind of in and out of consciousness. That's why it's called twilight. So,
Conscious sedation for the first 10 minutes of the case, right?
yeah, conscious sedation for the first 10 minutes. So. Listen, you're not going to find a better anesthesiologist anywhere for this procedure than Dr. Berndes. I don't hire schlubs. I hire only the top people. And I only want the best people to work with me. There's cheaper anesthesiologists out there, but they hurt people, they hurt patients, and I don't want my patients getting hurt. So I invest in the best. I like that, invest in the best. A new slogan. All right, questions?
Next question comes from Wizzy on YouTube.
Lizzie?
Yes, Wizzy with a W.
Lizzie, okay, great. Welcome.
They ask, can a long-term bench press gym exercise cause flat neck/back syndrome?
No. No, bench pressing in the gym is not going to cause flat neck or flat back. Nope. You can get muscle spasms. It sounds like you've been talking to a chiropractor. You got to watch out. Those chiropractors are, a lot of them are dubious, okay? Not all of them. There are some really good ones that really care, and they want the best for their patients. But some of them are just tricky little sleazeballs. They'll show you your spine on a special x-ray. You'll see it straightened out, and they'll tell you that you need to keep coming back and getting treatment from them, but you really don't, okay? You really don't. There's a lot of shady people, unfortunately, in healthcare that, you know, do treatments that are, I think, completely unhelpful and unnecessary, but that doesn't stop them from doing it, because they make money doing them. So be careful who you take advice from. But definitely bench pressing, there's nothing in the gym you can do that's going to straighten your spine. Now, you can hurt your spine in the gym, and I always tell people avoid deadlifts, clean and jerk. If you're going to press, like military press, make sure you don't overdo too much weight. You're going to hurt your lower back, okay? And I think getting in the gym is great. I think it's very important to stay fit, healthy, strong, build your core, stabilize your body and your spine. But you got to be careful. There are some exercises that are just plain bad for your spine. And deadlifts, clean and jerk. I think hack squats are not good either. Sorry, but they're not. They put too much strain on the lower back in a very unnatural way. It can harm your discs. All right, just about done. We've got about 5 minutes max left. This is a very firm herniation. Firm as in scarred. Herniations should be soft. Normally, herniations are soft when they come out, like a little baby. But over time, under the action of inflammation, they become hard, firm, scarred. Just like humans, right? We all start out as soft little babies, and then life's lessons make us more callous, more scarred, more tough, and that's what these herniations are right here. They've been around for a while. These are more like adolescents, you know? They're stubborn, a bit scarred up, but not the most scarred I've ever seen. Just about done, and then we're going to end this broadcast. So if you have questions for me, this is the time to ask me. How much laser energy have we delivered so far? For this disc? All right, thanks. So 10, what is it, 10 joules? Luis? 10 watts? Or kilojoules? Huh? What does it say? Besides the 10, next to the 10, what does it say? Kilojoules, all right. So we've delivered 10 kilojoules so far to this disc, is that correct? Yes. Yeah. I would say our average is probably closer to 15, 20. So it's not too bad. We're not done yet, but there's another piece of herniation. We'll probably finish up around 20. A lot of these herniations are stuck. All right, getting into more scar tissue here. See how white and thick it is? Scar tissue. Great questions from our audience. Any more?
Yes. last but not least, from Ali on Facebook, they asked, do you find that some people have carpal tunnel issues in addition to their arm/hand pain from the neck? And do you help with carpal tunnel if that's the case?
Yeah, we do treat carpal tunnel here. I try to avoid it. I only treat it in patients that are my patients that I've done spine surgery on, because it's just not a very complicated surgery to do, and it's done all over the place. We focus on treatments that are not really offered elsewhere. So we will do a carpal tunnel, and we can actually combine it with other treatments if you need it. The way we diagnose it is through a nerve test. We want to get a nerve test done, verify you have carpal tunnel. We do those nerve tests here. If you've got one already, that's probably fine. I just need to look at it. Just about done. I think one more minute. We're starting to get a few pieces of deep herniation that I shoved in earlier. When I put the dilator in, they kind of went deep, and we're getting all those out at this point. Remember, herniations are going to be loose fragments, usually just tethered a little bit by the scar tissue from inflammation. All right, should be just about done here. Looks like we're at the outside of the disc in the epidural space. "30 seconds. I would say scope use is I mean, it already started out bad, but I would say it was an 8. 8 out of 10. I'm making you guys all experts at this surgery. Some of you have been coming for a long time, watching these surgeries. It's good. I love it when people show up and they say, I know what I want. I want the Deuk laser disc repair. Just tell me which discs I need fixed. That's somebody who's done their homework.
We have another question.
Sure.
This comes from 2 questions, actually. This first one comes from Ali, once more on Facebook. And they asked, are all patients intubated?
No. No, they're not intubated. This patient is not intubated. They're breathing on their own. They have a little bit of oxygen, nasal cannula, maybe a face mask once in a while, but they're breathing on just supplemental oxygen, we call it. Breathing on their own. There's no intubation. All right. Little ghosts. Any more questions? Because we are pretty much done here. I'm going to end this live stream.
Last question comes from Wizzy on YouTube.
Yes, Wizzy.
And they ask, thanks for the explanation, and what could be the possible cause of flat back and neck syndrome?
Well, first of all, I don't know that you have flat back. So, but let's say you have flat back. I don't know how old you are, but age is a factor. If you have facet joint pain, you can develop flat back syndrome. But that's typically in older people, usually 40 and over, where if you stand up straight, you have back pain, it makes you bend forward. Eventually your spine is going to shift from the facet joints, causing so much pain and developing arthritis, you can get a flat back. The discs can also collapse in the front of the spine. If you have degenerative disc disease with severe collapsing of your discs, like 90% loss of height, over multiple discs, you can develop flat back. But, you know, like I said, a lot of these chiropractors and therapists are over-diagnosing flat back just so they can treat you when you don't really have it. All right. We're going to bring our x-ray machine back in. We're done with the broadcast. You can end it.
Copy that.